An FYI, Rep Schlossberg is joining us. So I don't know if we wanted to, he said he'd be right here in a couple seconds.
He's here.
Oh, he's here? Oh, I didn't even see him.
All right, I'm coming in. He's coming in now. All right. Okay. So I don't see him on my screen. Oh, there's Representative Schlossberg. Hi, Representative.
Everyone,
So nice to see you.
I see you all.
Thank you for being here.
My pleasure, and thank you very much for having me.
So for those who are on the call, my name is Valerie Ferry. I'm the Executive Director for PPLC. We have lots of folks here joining us today, Representative, some from the PPLC, some who are friendly partners and other capacities. So they're all putting their contact information in the chat. So we have an understanding of who's with us here today. But thanks for joining us. We really appreciate this time with you and your staff. We were really interested in this idea of opening up the Mental Health Procedures Act. And as we were talking about it internally as a group, I think that we had more questions than suggestions on what would be happening if something would happen with opening up the Mental Health Procedures Act. So what we were hoping to do was just ask a little bit of clarification, get a little bit of context around your thinking, your office's thinking around opening up this act. And then there might be some additional questions related to the act. There might be some suggestions or some things to be thinking about as you're looking at that. So does that sound like an okay plan?
Absolutely. Looking forward to speak. I see a lot of faces that I recognize, more than a few that I don't, and it's wonderful to be here with all of you and to see so many people who are obviously invested in this area.
I think you got the attention of many, many people with this idea. So,
well, there's your first, my first mistake or yours. We'll find out.
I don't know. Who knows? So I think that the biggest thing that our group was really hoping for was just to have a better understanding about your motivation to take another look at the Mental Health Procedures Act. Would you be able to talk a little bit more about
I would be more than happy to. And it started from a variety of places, not the least of which, frankly, is talking to quite a few of you. Mental Health Procedures Act was first written in 1976. It's had some updates, I think, since like the mid 90s, and then a couple of others that are smaller. We obviously added AOT, and was it 2014 or 2016, something like that. Made a few amendments since then. The challenge that I've had in talking with more than a few people is that there's concerns that the act is really, really out of date. I'm coming at this more from the perspective of what can we do to ensure that it operates smoother and that it's more reflective of some of the workforce challenges that we have today. So the conversations that we've had primarily about updating have been who can do what, when and timeframes and when things are done, and trying to smooth out some of the differences in interpretations between counties. I know that every different county seems to operate the act in a little bit of a different way. That's not ideal, to put it politely. And I think we'd be happier if we were in a spot where we could potentially make sure that the act operated uniformly throughout the state. That's where we're coming at it from. There were initial conversations of could we look at potentially either, there was, can you do something about scope in terms of people who have substance abuse challenges? But there's been, no shortage of pushback on that front. And I think where we're kind of at more than anything else is trying to update the act and smooth out interpretations. So that's something that we're doing. We've had some initial conversations with the House Judiciary Committee about potentially holding hearings, assuming that we are still in the majority next year, which I hope we will be. So that's something that I think will be explored. We're going to be talking with DHS as well. I see Dr. Adair on the call. We'll be talking obviously with Dale as well as Deputy Secretary Smith. And also, I should have done this at the beginning. Let me introduce you folks to the brains of the operation here. I have two staffers who are on this call. Joining me is my executive director, John O'Donnell, as well as my former executive director, Rachel Maurer, whose talents were acknowledged by those above me and now works for Leader Bradford. But Rachel will still be very involved with things that we're doing in mental health, including certainly this project.
Thank you for the introduction to your staff. And sorry, John, I met you before and I apologize for that.
It's relatively new. This only happened a few weeks ago. So
congratulations, Rachel. That's very exciting. Okay, so if I'm hearing correctly, what you're saying is you're looking to sort of smooth out some of the previous interpretations, get some uniformity around what that looks like county to county. And that you had taken a look at the scope, but you're understanding that SUD is a bit more complicated in putting
More than yes. Well, and it comes down to a matter of scope and manpower. I mean, we don't have the resources to potentially expand who would be impacted by the act. I will say some conversations that we've had with law enforcement, some of our folks have expressed an interest in potentially applying additional resources to people who may be violent. And I don't even mean longer timeframes. I mean potentially making it easier for law enforcement to check in on folks if there is additional risk factors even after discharge. So that's something that we might want to explore as well.
So I would like to open this up to some degree to the group, particularly to folks who are part of the initial PPLC discussion, although there are many folks here who may have questions. I know that there were some clarifying questions that folks may have around potential challenges to opening up the Mental Health Act, Procedures Act. So would anybody care to speak on that, particularly folks who might be interacting and interfacing with this process on a regular basis? Don't everybody jump in all at once now.
Well, okay, since you offered. Lloyd Wertz here. Hi, Mike. So glad you're with us.
Hey, Lloyd.
Appreciate it. I happen to be in a different time zone, so things are looking a little funnier here, but awful good to see you. In the past, Mike, there have been a number of discussions about the possibility of opening up the Mental Health Procedures Act and the grave concerns that perhaps by legislating the process of mental health procedures imposition, that we might lose some capacity to deal with patients as individual counties or their circumstances might dictate. There's also a concern about, we really want to find a way to deal with the substance use addiction population. But even if we somehow were to make those who are suffering from substance abuse and addictions, even those who have attempted to overdose, either intentionally or otherwise, that they might become part of an involuntary treatment for therapy, for commitment. And Mike, I have not yet visited a drug and alcohol rehab program with a lock on the door. They're all voluntary. You can have legal requirements to be there, and if you don't stay, maybe you'll find another place that does have a lock on the door. But in most cases, the potential of treating folks who have substance use issues is just significant. So there's that kind of concern out there. And I know there are some people who still think that ought to happen, and perhaps the Mental Health Procedures Act could be a vehicle for that. But there's concern. Having been a county administrator, admittedly, a number of decades ago, I can tell you that as much as I dislike the Mental Health Procedures Act, I was able to work with it. And that, I'm not saying that's necessarily the case today, but basically proceed with caution as we go forward with any rewording of something of this level and this magnitude. Those are my words.
Just said, I'm sorry, Lloyd. I didn't.
No, go ahead.
You just said something very interesting, which is making sure that counties can maintain flexibility. I think that's something that's a balance that we do need to strike. The challenge that I've had, we've heard of too many circumstances where counties where somebody can get discharged in one county and wouldn't in another, or where you have situations where you're setting somebody up to be boarded potentially for a long period of time in direct violation of the act. Neither of those situations are what we want, and I don't think that's ideal for patient care or for society as a whole. I don't know how you strike that balance. I do know that that whatever way we can continue to provide counties with flexibility based on their specific situation in terms of facility, bed space, workforce, et cetera, that's something that we need to do.
Yeah, the issue of county flexibility also relates to the type of services that counties have in place. Some have assertive community treatment teams. Okay. Others, like mine here in Schuylkill, do not. I note that Dr. Serta, a clinician, a well-practiced and advanced clinician, has his hand up. I'm wondering, Ken, if you want to add to this discussion.
Well, sure. And of course, you and I have spoken about this to some degree in the past. The big, I mean, how the different counties enforce the act is troubling in many different ways. And it is absolutely true that what gets committed on the streets of Schuylkill County are very different than what gets committed on the streets of Philadelphia County. And there should be some reasonable discussion. Is that okay? Because we're certainly very different people. We're very different, at least social structures and geographic structures. But I mean, one question I have is, can we get the counties to toe the line? You know, for a while there, as some people on the call knows, some counties wouldn't use 302 petition that was on a form that was made in another county. And I'm not even sure how that got resolved, but that's the kind of thing that would be really helpful to do. And then the very serious problem of the people who come into ERs, because I mean the act was drafted, I mean, originally back in '66 when there was nothing like the ER system that we have now. People get brought into ERs, they have medical conditions that cause them to be in the ER. And when does the clock start ticking on the 302? And having ERs filing 303s when somebody who's never seen the inside of an inpatient unit yet just seems wrong. So that would be one thing that would be nice to figure out.
Absolutely. Absolutely.
But can we get the counties to toe the line? What constraints do you have?
Do you mean that to me, Ken, or do you mean that just broadly speaking? Because I don't have any constraints to. The challenges that I'm looking to address more than anything else are ones of interpretation and a lack of uniformity when we can. At the same time, trying to strike that balance between uniformity and flexibility is difficult. And let me also kind of take a step back and talk about where we're at in the process right now. We're really on a fact-finding mission. I've had meetings with a few of the folks on this conversation already. I will inevitably have many more, and that's good. That's what we want. I have heard about the problems. I will not pretend to have the solutions. And what I'm asking from folks who are involved in this area is both, is a list of what some of these problems are and what your recommended solutions are. That's where we're coming at this from right now. And we are not, like, just to be very, very clear, there's 6 session days left. You know, this isn't something that's going to be addressed anytime soon, or we will not have legislation drafted anytime soon. So this is very much in the early stages of conversation.
I appreciate you pointing that out. I failed to mention that this is not legislation that is already on the move, that this is an exploratory conversation. So if everyone could just keep that in mind as we're having the discussion. I see Jim, Crystal, and Dr. Adair. I also see your hand, so I'll make note of that as well. So Jim, I believe you were next.
Great, thank you very much. Representative Schlossberg, always a pleasure, and thank you for continuing to be our mental health champion in Harrisburg. It's refreshing and a pleasure. Just to pick up where Dr. Serta was, I agree that a lot of this is applicability. Mike, you mentioned that, you know, we want to identify the challenges, where the uniformities, are there flexibilities? And I'm going to steal a line from Deputy Secretary Jen Smith in our need to modernize regulation or modernize statute. And I know you're looking for intersex or where we might be able to do it. And I know you kind of talked a little bit about it there around, as opposed to eating the whole elephant, so to speak, are there pieces that this group can make recommendations on that might be most impactful? Certainly there are some language changes, obviously, from 1966 to now, and I think those would be the low-hanging fruit. But
yep.
I think in those areas that eventually that we're going to focus on, I don't think they're enumerated, but I don't think they're overwhelming in the scope to be able to do this. So maybe looking at those applicability areas.
Absolutely.
Looking at the intersex where Dr. Serta finally points out, how are we interpreting this? It looks different in Philly than it might even look in Lehigh or
yep.
in Montour County. So I think as your fact finding kind of moves this forward, you know, I think that might be a consideration that you don't have to undo the whole thing, but there's certainly low hanging fruit. And then where does the rubber meet the road in terms of the applicability?
And I think the nice thing is that there's enough, inevitably stuff we propose is going to anger somebody. And, we're obviously all familiar with the controversy surrounding the MHPA. The goal here is to try to be able to do the most and get the most possible done. And I think everything that you just said, Jim, is something that we could potentially do and get widespread agreement, especially doing this in again, that's why I want to emphasize again, we're not in a position where anything even remotely approaching a draft is put together. Like, we really are just on the fact finding right now. And everything you just said, Jim, has been reiterated over and over again with relatively little objection. Now, when we start coming up with specifics, that's when the objections start. But that's okay.
Great. Well, thanks for the opportunity to be here. And
Always.
Thanks for your work.
Always.
Thanks, Jim. I want to point out that Rachel put something helpful in the chat, looking at common themes, which have already been brought up in some of their conversations. So if your comment has anything to do with any of that, maybe take into consideration some of the conversations that the representative and his staff has been having, and frame around that way of thinking. I realize we have quite a few hands up, so we'll go to Crystal, and then I've not forgotten about Dr. Adair, and we'll come back to Dr. Thompson. Crystal.
Yeah, so initially some of my concern is that people may use this as opening up as an opportunity to infringe even more on an individual civil rights than we already do. And I'm concerned that that may not be as protected as it should be. Not everybody looks at it the same way. So I am kind of worried about that piece. And the other is when you mention flexibility, when you do 302s, the rural counties don't have the services necessarily available, nor do they have the dollars to provide it in ways. And having done that work, you could spend, everyone's going to the ER to be medically cleared. Most of the rural counties have no hospital, they have no psych unit. They're sending everybody out, and that can take, we won't talk how many hours you may be sitting with someone, waiting for someone to come pick them up. So I think that needs to be understood, that what works in Philadelphia or even Schuylkill will not work in Elk or Camden County. And small counties like that. So, and having lived there lived in one of those, it needs to be considered as well.
No, I think just to add to that, I'll use this as an example. If I'm not mistaken right now, and somebody please correct me if I'm wrong, a 302 can only actually be formally issued in certain settings, right? It can only be issued in a hospital, if I'm not mistaken. Is that correct, Crystal?
Well, you're in the no. So the local hospitals are not going to, we're going to bring somebody in, and when they're medically cleared, they'll call a delegate out, because you can't talk to anyone who's not medically cleared.
Right.
So they could be there hours waiting just for a delegate to show up. So there's barriers there that other places don't encounter. And you have to be thoughtful about it.
That becomes the question then. What other things could we put into place that can reduce some of those barriers? How could we alter this so that, I'll use Carbon County as an example. Carbon County is a walk-in crisis center right now. Are there ways that we can, thanks, Ken. Are there ways that we can potentially better utilize some of those walk-in crisis centers? And then what impact would that have on some of the crisis center regulations that are going to be coming soon? Those are some of the questions that I have. And I'm curious about some of those answers.
Yeah. And I know there's different ways that a 302 can be initiated, but many of the small counties don't have mobile crisis, or your delegate is considered the mobile crisis. So it's just looking at it from all angles. The other thing is, no matter what gets created, you always have to be looking at what are the unintended consequences of what you wrote. And that is one thing I find government does not necessarily do well. So hopefully someone will take up that cause, because it could do more harm than good in the long run.
Right. No, all fair points, and thank you.
Thank you, Crystal. And Representative Schlossberg, you brought up an excellent question, which is, how does this look in real time? And I think you can see that in the chat and what Crystal's saying. It depends on the county and the community that you're in based on resources. And I'm wondering, does your staff have access to a good understanding of how this looks differently depending on, is that something that might be helpful?
Yes.
To give you sort of.
And you can watch my staff nod in the windows below. Well,
that would be very helpful.
Yes. And and let me, Me too. And the answer is no, like, because I know that I know enough to be dangerous, I guess. And I know that there's a variety of different pathways that can lead to a 302. Um, and here's one of the things that this conversation is actually helping me better understand just how differently it operates. I think that the question I asked about where a 302 can be issued was based on one county's operation of it versus another. And I think, frankly, that's something that would be really useful. Let me also add, this is not going to wind up just being the Mike Schlossberg effort, because if this actually rolls its way through, there have to be hearings about an issue this comprehensive. So it would probably run through judiciary or human service. I don't have specifics on that yet. I do know that there's going to have to be more conversations with people beyond my level as well.
Great. I think that there are lots of people who would like to help you understand, or anybody understand, the differences. But I think that if you're taking anything away, is if you've met one county or one community, you've met one county or community, particularly when it comes to this need. I want to come back to Dr. Adair because he's been waiting very patiently. So Dr. Adair.
No worries. Good afternoon, Representative. And you're going to end up having a conversation with DHS. So I would just draw, and this is probably more emphasis on some of the comments that's already been made. One of the issues with the Mental Health Procedures Act, as applies to a lot of legislation, is there are several different interpretations that then lead to some of the issues. From it's not all about county resources, although that is a large piece of it, but part of it is also the county solicitor's interpretation of certain things. So in quite honestly, I don't know how the legislation is up. I don't know a solution related to legislation. I think, quite honestly, I think part of that is DHS's ability to provide clarification, education, et cetera. But again, I'm not going to take a lot of time because we're going to have an opportunity to talk to you. But
no, but I understand what you just said, and that's a challenge, to put it politely.
Thank you, Dr. Adair. Dr. Thompson, I believe you're next.
Good afternoon, everybody. Good afternoon, Representative, and thanks for initiating this and allowing us to have a conversation with you about it. I have essentially two comments to make. One of them is, it does sound like this may be one of the challenges and limitations of our Commonwealth and our county-based system, that the interpretations there are therefore split into 60 different potential interpretations and 60 different levels of how the procedures are carried out. And I think that that's how you bring some uniformity, given that human rights, and what I take the main reason for the legislation was an effort to both square the issue of protecting people's rights, at the same time making sure that people were both protected and given opportunity for help when they needed it. So that's a challenge, but it shouldn't vary that much across the state, right? It's I feel a little bit like this idea of, I don't want to go too political here, but like, let's throw abortion rights to the states and then imagine that it's okay to have those rights vary greatly across the country. That doesn't seem quite right. So so there's an issue here, and how to square that, I don't know, but I do understand that challenge. But I want to raise a whole other level here. Just to keep it in the background, we've done a recent study. A recent study was done here in Allegheny County, where we found out that the number of people who are 302'd who die in the subsequent 5 years after being 302'd is around 20%. So we have a 20% mortality rate for people who've been 302'd in Allegheny County over a course of 5 years. There are particular groups of people who that's most impacting on, and we can go into more details about that at some other point. There are about 4,000 people a year who are 302'd. I should mention, by the way, it doesn't matter. It's actually 5,000 people are 302'd. 4,000 is successful, and they are, they are confined at some point, and 1,000 are not. the 1,000 who are not also have this high rate of mortality. So just even being 302'd at all for petition is a sign of impending possible death in the next 5 years. And I think we're talking about a public health issue. And how do we ensure that the folks who are 302'd, if we take that as some kind of a sign of their circumstances and the challenges that they're facing, both medically, psychiatrically, and socially, that we begin to think about what kind of resources and services are needed for those folks so they don't die at the level that they're dying now. So you're highlighting an area that I think it's a procedural act, but I think it actually has significance at a public health level.
Well, and I think I see Rachel typed a response to something only somewhat related in the chat, and it's true. You can't, obviously, this isn't an issue that exists in isolation. There are, in essence, there's two major mental health forces that we plan on rolling out this year, at least out of my office. I know many others will be doing many more, but this is one. The other is workforce. Specifically, we're looking at making major investments in workforce and in increasing the reimbursement rates. It's something that we've taken a run at in the past. We'll certainly be doing so again. That obviously requires cooperation with the governor, and we'll be speaking with him and his office as the budget unfolds. But we need to do all of this at the same time.
Thanks, Rich Schlossberg, and thanks, Dr. Thompson. Also a request from Dr. Serta, if you have that data where you have it, and I'm assuming, can you share it? That would probably be of interest of some folks in this group.
I can't say that it's on the Allegheny County Department of Human Services website, so it's there. I'll see if I can find it.
Joel is here.
Unfortunately, not always easy to find, but it's there.
Joel, it's nice to see you. I perhaps you have access to a place where folks can see that.
I do, and I will look for it and post it in the chat.
Perfect. Thank you. Appreciate it. Thanks for being here. Dr. Doherty, I see that you have your hand raised.
Thanks. Mike, thank you for taking on what's going to be probably an impossible task.
Great my life.
I think the issue really that we all are aware of is that the Mental Health Procedures Act has been around forever. The interpretations have become increasingly more complex. And being able to incorporate all of that into a new system is going to be difficult. The problems that we have are that it's creaky. It is inconsistently interpreted around the state, and it is increasing more unaligned with the landscape clinically that we have of how patients actually present for involuntary commitment or for admission in general, all of which are what we would like you to address. The concern, of course, is that if we get a massive change in process, how chaotic will that be in implementation around the state? And the awareness that when other commitment-related legislation has been proposed in the past, it has often been incomplete. So rolling it out and knowing how to, like, who actually handles what and how it's supposed to be done is not well defined, or there are areas in the other statutes that are just so vague that rather than clarifying the Mental Health Procedures Act, it has made it even more difficult to figure out and more inconsistent around the state. And those are the concerns that we would have in general. And so what I really would ask for you is if you can incorporate clinicians who deal with this on a regular basis in the development of the wording of the legislation, rather than waiting until the comment phase when it's rolled out, where there could be so many different things to be addressed that we're not even getting to them. That would be helpful. And
Absolutely.
I think you'll find probably everybody on this call, I'll put my hand up for that, would say we would love to be helpful, to be involved, to do what we can to help with saying, reading, reviewing, saying, we've lived this doesn't make sense, or this is terrific, or whatever.
No, and that, frankly, that's why we're doing this call right now, among many other reasons. Like that's, we were trying to be as open as possible, especially, and especially as this first gets started and we understand just how broad the challenge is, and that nobody in the legislature individually has the expertise to understand fully what we need to do. That's why we're here. So
And I don't think
certainly
any one
appreciate that.
person in this room does, because there's probably as many different agendas as there are people in this room. And that is one of our concerns, is how do you incorporate so many agendas?
Yeah. Well, and the answer, look, the answer here is you do the best you can, but you also can't. Like, you get as much as you can to be as good as you can, and then at some point you make a judgment based on the feedback, based on the information, and you write legislation that you think will do the best job possible. So we're obviously at the very beginning of this stage, and it's like a funnel. You start here, and then as you get closer, what you're looking at narrows a little bit more.
Thanks, Dr.
Sorry, just real quickly to follow up on that. I think there is also another level, and I think Mike would agree with me on this, on what will be politically possible. There is a level as well where there's going to be opposition that's going to be insurmountable. And so, again, the low-hanging fruit, we want to get as much of that across as possible, on the understanding that there will be things that we would like to see and that we can't.
We've made multiple efforts when it comes to updates to mental health or to mental health in general. This session, House, by a 171-30 margin, passed legislation that would have increased funding to behavioral health by $100 million, and it got deleted in the Senate. I mean, we've tried repeatedly. The governor made numerous valiant efforts to increase behavioral health care. He was successful in some, he wasn't in others. So, we've run in opposition, and we will continue to do everything that we can. I will add, it's why it's so important, and we've kind of started those conversations, and we will more so in earnest as we get closer. We've got to be able to incorporate these conversations with the Senate, and frankly, you folks more than me, because they might listen to me, but I'm still going to be another elected official, and people on the ground, your voice matters more.
Thank you for saying that, Representative Schlossberg. That is such important information. And I hope everybody had their listening ears on for that, because we just had a very long conversation, in fact, a day-long conversation about advocacy at our PPLC meeting on Monday, and sort of, what's the skin in the game that we're all getting involved in. Dr. Doherty and Dr. Serta put together a wonderful presentation to that end. So if you want a copy of that presentation on how to your legislator, either Rep. Schlossberg and your team, or anybody else on this call, I think we'd be happy to get that information to you.
Absolutely.
To get everyone talking more about this really necessary topic with everyone that we can. I do want to go to Dan, but first I had a little bit of a question. I think that when we talk about the opening of the act, I think there's been some discussion around some of those unintended consequences. And has there been any discussion around, are there ways to get to some of these concerns without opening that act back up? Is there a way to sort of, and I don't know if piecemeal is the right word, but has there been any discussion on how do we sort of target some of those challenges that are being seen by these groups, but maybe not necessarily opening back up the act? Is that an option?
So the answer, I think, ultimately starts with the hearing process, because so keep in mind, just looking at the legislative process in general, it would start with hearings, probably out of the Judiciary Committee based on the initial conversations that we've had, maybe jointly with Judiciary and Human Services. So you get legislators and staffers who have an interest and a level of expertise in both of these subjects, folks that sit down and figure out the best way to proceed. Proposal gets written, introduced, sent to one of those two committees, kind of goes from there. There's no way. The challenges that I hear about opening up the act and people being afraid of it come from roughly one of two sources, as best I can tell. One, there's something in the legislation that advocates in general, be it here or people who are otherwise involved, don't like. Or two, when you do this legislation, an amendment gets added to the legislation that creates a problem, that, expands the scope beyond something folks are comfortable with or whatnot. So how that gets prevented ultimately isn't through not opening up the act, because you can't have a conversation about the MHPA without looking at the MHPA, but it comes through trying to build the best coalition with expertise and doing so in a bipartisan way. Now, candidly, I obviously, no one person controls the legislative process, but if you do this the right way, you create an inclusive bipartisan process, you can ideally keep off any problematic efforts. I will say the comments that I made earlier about potentially, so there are some who would like to see the scope expanded or do something like in Florida through the Marchman Act. we hit walls with that very quickly, just based on initial conversations, including conversations with some folks who were here, as well as other legislators who were deeply involved with mental health. So I'm challenged to see anything that would expand the scope gaining traction based on the political landscape of Pennsylvania. Now, I can't control that, but that's just my initial thoughts.
If I could just add to, we're also in conversations with departments. So we're meeting with human services to kind of figure out what we can do from a human services end. I think we have aging, corrections, drug and alcohol, Department of Health, PCCD. So we're also trying to get in touch with them to talk more.
Thank you. Dan, you've had your hand raised, and then we'll go to Dr. Roth after you've had your comment.
Thank you, Mr. Representative Schlossberg and staff. There is a basic contradiction in this that I think you're going to find. I mean, there are 58 people on this Zoom meeting. My guess that means there are at least 58 different perspectives that you're going to hear at one time or another. One of the concerns is this was created as a legal act, which automatically brings the legal system into the mix, who have very different needs and very different expectations than the human service side. When we're talking about protecting civil liberties, we've already on the front end of this thing crossed that line.
Yeah,
because we are involuntarily.
it is.
We then put the police in the position of having to accompany us to a 302, generally transporting to the office to a hospital, either they or the EMTs, and then we want them to leave, and we want them out of the process from that point on. So when they ask the question of what happened, where did he go, what are you going to do now, our first knee-jerk response is, that's none of your business. Until the next time that we call them and ask them to do the same thing. So this is good luck and thank you, but it is going to be quite a journey. So
I hadn't thought of that, but I appreciate the perspective.
Thanks, Dan. Dr. Roth, you're next.
Yes, all of you, I'm sorry I was late in tuning in here, so I likely missed, something. But here is my question. I've been at WPIC, as many people know, for 50 years. And I also initially had a law and psychiatry program. So did you discuss the 1976 statute, which is the statute you're talking about, and why it was changed from the previous statute? Because unless you do this, you in effect are negating, you're not following any precedent or logic at all in some ways, because you need to know why the act was possible and how did it change from the past. And that can be very simplified. And Pennsylvania was a little late to the game because it really goes back at least to 1968, when there was a conclusion that need for care and treatment as the standard for involuntary hospitalization was fundamentally unfair and very broad, and it was very discretionary as it was operated. So that was the change which began in California to switch these statutes into the dangerousness category, and in effect to restrict this to people who were dangerous, or alternatively were so disabled, in effect, that they could not make decisions. So that was the first and primary objective. Although one could argue an equal objective, and some would say even more than equal, was to provide legal, shall we say, contribution to the patient so that they had someone to object if the patient was genuinely objective. And that is what led to the court hearings, which obviously have been not discretionary, but at some point definitely required. And then you're up to the question of how those individual lawyers are going to interpret that act, such as to really retain the patient or loose the patient. So those are the two major reasons. And presumptively, if you want to amend this or change it, you have a feeling that those type criteria, whether it's the legal protection or whether it is the dangerousness criterion, there's something wrong with them, or they haven't worked, or they're too variable from county to county. So I'll stop with that. But unless you really identify exactly why you are unhappy with the present law, and there may be a diversity of unhappiness, and it may or may not add up. So I will stop with this, because when I was Western Psych and teaching law and psychiatry, it was my job to educate the staff in 1976.
It is not, candidly, something that we've gotten into yet, and I will happily take any background that's necessary.
Well, that's in effect what I'm suggesting. I was not voting that you come to me. I was not voting that you come to me. But I think you also ought to tap into the views of the lawyers, and and somewhere whomever represents those lawyers in 60 different, counties.
Yep, absolutely.
Dr. Roth, I appreciate your historical context. I was hoping that perhaps we could talk a little bit about that today, and right on time. You absolutely delivered. So thank you so much for that context. I see that Matthew has his hand raised. However, Joan Ernie, you put a really important comment in the chat, and I was wondering if you would be willing to expand on that a little bit. Or not, it's up to you. Joan, can you hear us? Oh. Sorry. Maybe I can, let me see if it'll.
Oh, hey, hi, how are you?
There we go.
Good. Sorry, I'm technically challenged. So I had two comments and thank you for giving me a chance to jump on. I was a little bit late, I apologize. I had two comments in the chat. One was just a reminder that there have been many initiatives, or at least several that I'm familiar with, of trying to create that uniformity in interpretation, recognizing that, again, different communities might approach the Procedures Act, but it did require, I think it was the Bar Association, public defender, prosecutors, DA offices, and the state, who actually put together teams and did training sessions all over the Commonwealth for mental health review officers, local DAs, etc. It was very well received, and might be something to consider on the short term. Talking to the Bar Association and the state about, again, that reinterpretation. We had a gentleman who worked for the department who was just an expert and was so great at being able to clarify when we would get calls and challenges. So someone, creating those expertise or having that expertise was nice. The second is that there was a legislative initiative, a study that was done, I think it's 2021, that was looking at ER boarding that really laid out so nicely, you know, what it takes to create the continuum in a community. And it really took the approach. I believe it had, you know, a lot of stakeholder involvement, and it took the approach of, you know, what do we need on the front end? What do we need in an ER and hospital setting, and what do we need on the back end? In order to create this continuum and a commitment that we really want to enforce and prefer voluntary and engagement strategies, and having adequate staff and workforce to be able to do that. And then finally, my other, you know, comment, which I make on almost every call, is that, you know, these kinds of discussions really need to be driven by the people who experience commitments. And I think people with lived experience and their family members and advocates on their behalf really should guide this work in making any effort to change the Procedures Act or any act associated with mental health. You know, we need the resources in order to, and we need a commitment of resources to be able to get back on track with a system that's been really strong and recognized very strong over the years, but somehow we've been faltering here recently. So thanks for the chance to chat a bit.
Yep. No, and we have reached out to a lot of those parties and look forward to continuing to do so, including folks like First Got NAMI, a lot of our local organizations as well. Again, though, that being said, like that's not just the me part. Like they've got to be, yeah, I'll obviously happy to talk, but we want to make sure that they also participate in any sort of committee process.
Great, thanks.
Thank you.
John, appreciate the comments and your willingness to.
Oh yeah. Well, it has to be. Otherwise, we're not going to get it. First of all, it won't be good, and second of all, there will be too much political opposition. Like those are two no-brainers there.
Matthew, I believe you have a question.
Thank you. I wanted to just backpack off of Dr. Roth, being a graduate of the law and psychiatry program and one of the psychiatrists at the intersection of both the forensic system and the civil system. I think there are several areas that are really ripe, as Dr. Roth was saying, to identify both dangerousness and how we refine the Mental Health Procedures Act to make that more easily utilized by both parties. And I think those are areas, and I'm sure Dr. Adair would agree as well, that we engage with quite frequently. And the vagueness that's inherent in the current way that the Mental Health Procedures Act is written often leads to confusion or misuse of that act. And I think if we are able to kind of streamline that, identify the dangerousness with nods to how that was first created, you know, we're working with other attorneys in the Allegheny County area to talk about what specific parts of that, and not to bore everyone with the specific details and statutes in the Mental Health Procedures Act, but they're varied. We use them quite frequently, and interpretation is obviously a problem, but I can't imagine there would be a difficulty selling that as a bipartisan possibility to refine that, make that more streamlined for both the consumer and psychiatrists that are, you know, or clinicians that are utilizing that, and make it something that could be more easily interpreted, more clear, plain language, and using and changing those aspects of the Mental Health Procedures Act in a way that would streamline the process both for the forensic and criminal system that I'm mostly enmeshed in, as well as the civil system, which utilizes that on a more frequent basis. So I think there's definitely several areas that have high utility and high potence for change. And like Dr. Roth was saying, dangerousness and how those criteria were created is really one of those significant areas.
Definitely. No, I agree completely.
Dr. Lane. So I realize we only have about 10 more minutes left of our discussion. Barring any other pressing comments, I really would like to sort of hone in on what are some of the next steps that we can do to assist with this conversation, including, are there other people here, people who should be part of the conversation who may not be here currently? So we do have a few family members and perhaps folks with lived experience on this call today. It sounds like that's somebody who you're including, and that was certainly clear that we would like to see those folks who are experiencing the receiving end of the act to be part of the conversation. But are there other people who should be part of this conversation. So as this group is looking around and seeing who's here today, who should be here that isn't here? And that question is also to Representative Schlossberg and their staff. Who else are we looking to engage in this conversation?
So I think there's two groups in particular. Now, we've obviously spoken with CCAP and with some of the county behavioral health administrators. In fact, John and Rachel, we actually explicitly had a meeting with them. So we have met with folks. I think, honestly, the lived experience end, we've spoken with groups like NAMI. I would like to speak with individuals. More so, we will be having conversations with law enforcement as well. Ken and I've had conversation with local law enforcement, but I'd like a statewide perspective as well. I would love, here's something, especially as we have this conversation, I would love different case studies. So if you folks could provide explicit, like obviously de-identified, but like patient X went through the process this way, patient Y went through the 302 process this way, and how those folks, some of the specifics about what their experience was like and where improvements could be made. I think something like that would be good. We reached out, Rachel and John, we reached out to Kathy, if I haven't completely lost my mind.
We're awaiting engagement from them.
Okay, great. So we are trying to pick up as many folks as possible, and we will happily meet with pretty much anybody. I would also say, please, if you have specific problems and solutions, email them to Rachel, email them to us. We would be more than happy to talk.
One thing to jump in on that, something Mike has said in the past, and I want to make sure that gets highlighted here. If there's any part of the law that you have seen that has gotten in your way as a provider, as a police person, as a lawyer, if there is something that has actually gotten in your way and this is the section of that law, please let us know. If you have recommendations that we could draft up into legal language, let us know. We can't promise anything's getting in, but those particular, hey, it's page 7, it's line 4. Those things can be very helpful to draw our attention to where some of the problems are.
And again, to Valerie's point too, I think it's helpful to see what is legislatively not working versus what we can do non-legislatively, if that makes sense. So I think that's really helpful.
I see that there are quite a few thoughts coming through on the chat, and if it's okay, Rep. Schlossberg and Rachel and John, I will send you the chat so that you have
a
record of some of the good suggestions that have come along. I can also send you a recording of this discussion as well as some of the other materials that we had access to today. Dr. Thompson, I see that you've got your hand raised there.
Yeah, I guess I'm trying to sort out from what I've heard, and I maybe I'm just seeking my own clarification, but I'm not convinced, or maybe I guess I should say it this way. I don't know if the procedures are the problem with the Procedure Act. I'm more hearing that it's an absence of real resources to attend to people in a way that actually meets the clinical needs in a non-coercive way. In a substantial non-coercive way that is really plaguing the state, as opposed to how this procedural act gets carried out from place to place. I don't know that for a fact, but it feels like the real issue is we still don't have a really good crisis response capability, and we're not real good with follow-up for folks in a non-coercive fashion, and that drives then a lot of issues that come up when the Procedures Act is applied. But I don't know. I'd be curious if that's the right interpretation.
I think it's a little of column A, a little of column B. And actually, I think it's a lot of column A and a lot of column B, because I think both of those issues can exist at the same time. Digging into the Procedures Act has really helped to illuminate some of the challenges that we have within the Act, as well as some of the room for interpretation and the need for clarity. But unless we comprehensively address our research or our resource and capacity shortfall, we're not going to completely get where we need to be.
All right, so I realize we just have a few moments left. You know, Representative Schlossberg, I first want to thank you for having this exploratory meeting. I think you can see that when professionals are reached out to, they really want to have a say in what's happening. They really want to help shape legislation that helps improve the lives of the people that they're working with and serving. So thank you again for treating this with seriousness and doing your due diligence to pull in the voices of those who are working with this act every day. You know, I would always encourage you to continue to use this group and others to help tell a friend in the legislature. I think that we're happy to talk with anybody, no matter what side of the aisle they sit on. I think we all are very committed in making sure that we're helping the system grow in a fruitful and a positive direction. Anything last for the good of the order? Anything else for you, from you, Representative Schlossberg, or your staff? Anything else that we can be helpful on in this endeavor other than?
No, I am good, and I know Rachel has to run, so if she didn't leave already, but I am good and also deeply appreciative. Thank you all very much for your time and expertise, and please know we want to hear more. So everything you got, please send it our way. We'll be moving forward on this, you know, in the new, ideally, at some point in the new year, in the new session, assuming the political situation stays the same, we'll start with hearings. I mean, that's kind of where we thought we would wind up being here.
Thank you. And you have a wealth of knowledge on this call. If you want to call on any of us, I'll volunteer folks here that they'll
Understood.
work with
Well put.
the group to help get them good information. I will have Lucienne put this recording into a YouTube file, and she can send it to you all so you can take a look. As well as some other resources, probably, you know, not today, but in the next following days, we'll probably have that out to folks.
Sounds fantastic.
Thank you.
Thank you very much, Valerie, and thank you everybody else. I really appreciate your time.
Thanks, everyone.
Bye, folks.
Bye.